Hi guys, welcome to my YouTube channel. I am Denmark Aranas, a fourth year medical clerk, and I basically provide informative videos to medical students. And also, I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe to my channel. And also, click the notification bell to be updated of my videos, for I will be posting new videos every week. This video is part of my approach series where I discuss the proper attack to certain chief complaint. This is basically a guide in giving the appropriate questions to ask in history and point out certain PE maneuvers to consider. Please take note that diagnostic examinations and management plan are not part of our discussion in this approach series. So for today, our topic is the approach to loss of consciousness. Seeing someone unconscious on the ground is a very alarming scene, and emergency room visits due to this is very common. What we should be most worried of would be sudden deaths related to loss of consciousness. We have seen young athletes after a game dropping dead due to a silent heart disease not detected early on. So, in this lecture, let us raise the awareness of how dangerous the cardiac causes of loss of consciousness really are. Here is the topic outline. First, I'll be defining what loss of consciousness is. Then, I'll be differentiating syncope from seizure. Then, we'll be focusing on syncope and giving its definition and emphasize on the importance of mean arterial pressure, then talk about the various differential diagnoses with the account of history taking and PE. Okay, so what is loss of consciousness? It is a state in which the brain has abolished certain reflexes and functions so that the person cannot relate with the environment nor has control over his or her own body. It is commonly referred as fainting or passing out. Loss of consciousness is a classic presentation of both seizure and syncope. Let us differentiate the two according to pathophysiology and fatality. As for seizure, it is related to aberrant electrical activity in the brain, while syncope is related to decreased blood flow or perfusion to the brain. With regards fatality, seizure has lower potential of fatality compared to syncope where the fatality is higher. For this presentation, I would like to focus more on syncope because of the associated higher mortality with it, and seizure will be discussed on a separate video. Let us further characterize the two using this table of comparison. The duration of loss of consciousness for seizure is longer, unlike syncope, which occurs only for seconds. Jerking, loss of bowel and bladder control, tongue biting are frequently observed in seizure. Unlike syncope, these presentations are rare. Prodrome does not really help differentiating the two because patients who had seizure or syncope may experience the same prodromes. Electrical encephalogram is obviously normal for seizures, for syncope, while abnormal for seizures. And the most important differentiating factor would be the duration of return to normal after the loss of consciousness. As for seizure, it is slow and gradual, while for syncope, it is rapid. Syncope is a reflex reaction of the body in response to decreased cerebral perfusion. And once the patient falls, and assumes a supine position and blood flow would easily get to the brain, the patient would immediately recover. Now you know the difference of the two. Let's now focus on syncope. First, let's define what it is. It is the loss of consciousness and postural tone due to decreased cerebral blood flow and associated with spontaneous recovery. Loss of consciousness occurs when perfusion ceases for 6 to 8 seconds and at a systolic blood pressure of 15 mmHg or less. An important determinant of syncope is mean arterial pressure or MAP. MAP indicates the degree of tissue perfusion to vital organs, and it is usually normally 70 to 110. And to ensure cerebral tissue perfusion, it should exceed 70. And it is calculated using this formula shown here. Here I present to you the factors affecting MAP. Those diseases affecting the systemic vascular resistance are related to the changes in systemic circulation, while conditions related to preload affects the fluid volume in the body. And lastly, the greatest factor affecting MAP would be the cardiac-related pathologies and that causes derangements in pumping of blood. That is why I would like to categorize the various differential diagnoses according to cardiac and non-cardiac causes. Let's go first with cardiac etiologies. The cardiac causes of syncope have the highest mortality rates. 5-year mortality rate of 50% and 1-year mortality rate of 30%. Under cardiac, we subcategorize it to structural and rhythm abnormalities. As for structural, I would like to highlight these two: hypertrophic obstructive cardiomyopathy and aortic stenosis. Let's go first to hypertrophic obstructive cardiomyopathy or HCM. It is the pathologic thickening of ventricular wall and septum, as you can see here. Familial history of sudden death and syncope should be extracted from history, as HCM has an autosomal dominant transmission. Also, take note of the clinical presentation of HCM. It is usually occurs in young patients who are competitive athletes. And the precipitating factor of syncope is exertion. As for the PE, you have to note for the classic murmur it has the harsh mid-systolic crescendo-decrescendo murmur. It is heard louder during Valsalva and at standing up, and softer while squatting and at Trendelenburg position. What I want to emphasize would be the importance of cardiac screening of young athletes. HCM is the leading cause of sudden cardiac arrest in young athletes. It is responsible for 36% of deaths in young athletes, and 90% of these deaths occur during athletic activities. As future physician, please remind your athletic patients to undergo cardiac screening to prevent sudden cardiac death. As for aortic stenosis, it occurs more in males and among the elderly over the age of 65. Etiologies of it include congenital, complication of rheumatic fever, infections, and more commonly associated with calcium buildup related to aging. As for the history, you should take note of the following symptoms: chest pain, fatigue, shortness of breath, difficulty when exercising, lightheadedness, dizziness and fainting, edema, and heart palpitations. And as for PE, take note of the diamond-shaped systolic crescendo-decrescendo murmur, the decrease, delay, and prolongation of pulse amplitude, classically known as pulsus parvus and tardus. There's also paradoxical S2 and S4 when there is left ventricular hypertrophy, S3 with left ventricular failure. So for HCM, remember it's for young competitive athletes, while aortic stenosis are for male old patients. We go now to arrhythmias, which could be slow, fast, or mixed. Sick sinus syndrome and AV block are under bradyarrhythmia, ventricular tachycardia and supraventricular tachycardia is under tachyarrhythmia, and lastly, we have the long QT syndrome. For bradyarrhythmia, let's discuss the sick sinus syndrome. It occurs as a result of disease in the sinoatrial node, and it may cause the tachycardia bradycardia syndrome, which the rate varies from fast to slow and back again, and it may manifest as syncope. Here are the intrinsic causes of sick sinus syndrome. Check this in the past medical history if the patient was diagnosed of any of this: amyloidosis, connective tissue diseases, hemochromatosis, sarcoidosis, ion channel dysfunction, or if you note the remodeling of sinoatrial node. For PE, check the pulse rate of the patient to detect the variations in rhythm. For tachyarrhythmia, here are the cardiac and non-cardiac causes of ventricular tachycardia and supraventricular tachycardia. In the history, check for these comorbid conditions that may predispose the patient: having a heart disease, severe pulmonary hypertension, or endocrine abnormalities like thyrotoxicosis and pheochromocytoma, iatrogenic by the medications taken by the patient or post-operatively, and others like obesity, excessive alcohol intake, or obstructive sleep apnea. For the signs and symptoms, remember the mnemonic collapse. So C for chest pain, O for oxygen, SpO2 is lower, L for lethargy, A anxiety, P for palpitations, S for shortness of breath, E elevated ventricular rate or heart rate, dizziness or syncope, or fainting. For the long QT syndrome, that is how you would see it in ECG. There are longer QT intervals. It could be associated with congenital genetic dysfunction of ion channels or acquired through various disease conditions listed here. As for the risk factors, females are more predisposed to having it, and certain activities like swimming, emotional stress, and sleep have been associated too. And of course, those who are taking prolonging drugs. Let's now proceed to the non-cardiac causes, and for you to remember it, take note of the mnemonic VENOM. V for vasovagal syncope, E for electrolyte and metabolic derangements, N for neurogenic syncope, O for orthostatic syncope, and lastly M for medications. Here is the pathophysiology of vasovagal syncope. It is related to the stimulation of vagus nerve that would lead to vagal discharge, and that would result to cardioinhibitory response, including bradycardia and vasodilation, ultimately causing frank hypotension, which would cause the decrease in cerebral blood flow and would manifest as syncope. So, what are the factors that stimulate the vagus nerve? Here we have three: the involvement of visceral organs, the baroreceptors, and psychogenic causes. The vagus nerve is all over the viscera. When straining, like during urination, defecation, coughing, sneezing, weightlifting, and Valsalva maneuver, there would be an increase in intrathoracic pressure, and this would all lead to increased vagal discharge. As for baroreceptors, the carotid bodies are the ones involved. In the case of boxing, a jaw shot stimulates carotid bodies by applying pressure on it from the punch, which would send signal to the brain that the blood pressure went high. The vagus nerves respond to this by inducing frank hypotension, and in the end, the boxer would end up knocked out and drop. Well, this could also be seen in people who have neck compression from wearing tight ties. When one moved the head, the person suddenly fainted due to the pressure applied on the carotid bodies. As for the psychogenic causes, fainting at the sight of one's own blood, emotional, traumatic, or stressful life events are due to the stimulation of vagus nerve. Also, and recent studies associate anxiety, major depression, and panic disorders as significant risk factors of it. The common denominator of the three are the fact that they are situational, meaning you may identify a precipitating event of the syncope and that they are recurrent and reproducible, and also associated with prodromes. So patients must identify the triggers and avoid them to prevent an episode of syncope. For the PE, uh, like what I said, it is reproducible. So an important maneuver to detect vasovagal syncope is to do carotid massage. Massage for 5 to 10 seconds, however, should not occlude it, done supine and upright. And if there is 3 seconds asystole and or 15 mmHg fall in systolic blood pressure, that is a positive carotid sinus syndrome, confirming the vasovagal syncope. We now go to electrolyte and metabolic disturbances. Sodium and calcium are associated with altered mental status and syncope, while potassium and magnesium are associated with weakness. Metabolic factors like hypoxia and hypoglycemia also lead to syncope. So in the history, check for the time of the last meal of the patient, or if the patient has any renal problems or in diuretics. And in PE, check for O2 saturation of the patient and also the presence of dehydration. Next is neurogenic cause. This is due to the poor perfusion to the posterior circulation of the brain. Vital brain structures such as the brain stem, occipital lobes, and cerebellum are supplied by the vertebral and basilar arteries. When blood flow is blocked, that would lead to vertebrobasilar insufficiency. Patients would manifest with focal neurologic deficits such as unilateral or bilateral motor or sensory symptoms involving the face or limbs, and unilateral or bilateral visual field defects. Could also manifest with vertigo, diplopia, dysarthria and dysphagia, loss of balance, and isolated sensory symptoms. Blockage of arteries is commonly due to atherosclerosis. So, in the history, check for the patient's risk factors like chronic hypertension, diabetes, and even smoking. For PE, do a complete neurologic examination of the patient and check for the motor and sensory function of the patient once he or she wakes up. As for the orthostatic syncope, it is related to postural hypotension. When a person suddenly stands up, there will be a decrease in the venous return to the heart and the blood would pool in the legs. But in young individuals, the nerve fibers detect these sudden changes in the body and respond by vasoconstriction. However, the old ones has already an impaired autonomic nervous system, so the venous return fails to catch up and that would cause them to collapse. So aside from the elderly, it could also be seen in patients with Parkinson's disease. And orthostatic syncope is also related to decreased volume of fluids in the body, as in the cases of diarrhea, dehydration, diuresis, and hemorrhage. So check for these factors in the history. For the PE, you could do orthostatic vital signs, where you take the BP from sitting to standing, and you would note a fall in systolic blood pressure greater than or equal to 20 mmHg, or a fall in diastolic blood pressure greater than or equal to 10 mmHg. Here are the medications that are implicated in syncope. First category of drugs would be those that cause reduction of blood pressure, such as antihypertensive drugs and diuretics and nitrates. There is what we call nitrate syncope. Nitrate is a drug used for angina. The main action of nitrate is to cause venodilation that will cause decreased venous return and eventually result in decreased cardiac output. And that could also result to syncope. Drugs related to reduction of cardiac output includes beta blockers and digitalis. Those that prolong QT interval would be tricyclic amines, phenothiazines, quinidine, and amiodarone. And also agents that alter sensorium would be alcohol, cocaine, sedative, and analgesics. And drugs that alter serum electrolytes would be diuretics. Well, that's it. I would like to end my presentation with a quote from Paulo Coelho from his book that I love, The Alchemist. Here it goes. Tell your heart that the fear of suffering is worse than the suffering itself, and that no heart has ever suffered when it goes in search of its dreams. For your patients, please don't forget to do cardiac screening for your young athletic patients. That way, you would prevent sudden cardiac deaths to happen in the future. For you aspiring doctors, you know that being a doctor is hard and you may fear the suffering you might go through. But that fear is not healthy for you. Do not let that to stop you in reaching your dream, being able to help healing someone or saving someone's life in the future. For you medical students, I know it gets harder and harder every year that you go nearer your goal. For the upcoming clerks, I too had the same fear as you. Before entering clerkship, I feared about emotional and physical struggles. failure, losing a patient, and being incompetent. But those things were conquered as I realized that I needed to go through this process for the sake of my patient. I need to really learn and go through this hardship to make me the best physician I can be in the future. So fight all your fears and tell your heart that you need to continue dreaming on, no matter what difficulties may be ahead of you. Thank you for listening. Have a good day.